Good morning or good afternoon, everyone. My name is Philippe Garcia. I'm an anesthesiologist and intensivist at the University Hospital of Nancy in France. First, I would like to thank Professor Glen Hernandez and the scientific committee for having me today. So this is a new recording of the session. Because apparently my connection was breaking pretty badly. So I'm really honored to be here with you giving a lecture for this outstanding online event dedicated to tissue perfusion with so many amazing physicians. So let's kick off this topic with about microcirculation and venous congestion. So I have no conflict of interest to declare regarding this presentation. So let's start with these questions. Are all these patients congestive despite different clinical phenotypes? Do all these patients present microcirculatory alterations? And if so, are these derangements related to venous congestion? These are, of course, tricky questions, and of course, as you can imagine, there is no easy answer. So tissue perfusion is determined by vascular density and by flow. The functional vascular density of the microcirculation represent the diffusive component of the microcirculation and corresponds to the total number of capillaries actually perfused with normal or hyperdynamic flow. Whereas the total vessel density comprises all the capillaries perfused or not. The convective component is mainly represented by the flow of red blood cells within the microcirculation and the proportion of perfused vessels, and is therefore determined by the capillary driving pressure, meaning a difference in pressures between the pressure at the entry of the microcirculation and at the exit. So there are a lot of clinical parameters and devices to appreciate microcirculatory alteration at the bedside. However, if you want to accurately evaluate the nature and the type of microcirculatory derangement, only handheld intravital microscopy can provide a comprehensive picture of the situation. While other tools can identify that a microcirculatory derangement is present, they just can't tell you what's causing it. Either a convective or a diffusive problem, or even both. So this is particularly true when a loss of hemodynamic coherence exists between the macro and the microcirculation. So Professor Janin Shea nicely conceptualized 4 types of microcirculatory alterations that can be seen at the bedside using HVM in rather preserved systemic hemodynamics. So the type 1 represents the heterogeneity of microcirculatory perfusion and flow corresponding to a mix of flowing capillaries and non-flowing capillaries, or intermittent flowing capillaries. So this is the hallmark of the microcirculatory alteration seen in sepsis. The type 2 is defined by a reduction in oxygen carrying capacity secondary to hemodilution and the lower capillary hematocrit. The type 3 is the one that we will focus on. So there is a global stagnation of the red blood cell flow due to either an increase in arterial resistance, namely excessive vasoconstriction, or an increase in venous pressure, causing an hindrance to the flow. And finally, the type 4 corresponds to an increase in oxygen diffusion distance, mostly secondary to tissue edema following capillary leak syndrome, for instance. So although the description of the different types of microcirculatory derangements is important, of course, it is largely theoretical because it is not that clear-cut at the bedside of the patient, and it's actually way more complex. So this description has been embedded in the guidelines on the assessment of microcirculatory sublingual microcirculation. So it is a set of 25 recommendations, but interestingly, there is not much said about the venous part, at the exception of the pressure artifacts, but we will come back later on this point. What happens to the microcirculation in the presence of venous congestion, that is an increase in venous pressure? First, according to the Poiseuille's law, an increase in venous pressure reduces the delta pressure along the capillary, and as a result, the flow will be reduced as well. Another hint to the mechanisms behind microcirculatory alterations induced by venous congestion comes from the Pappenheimer and Soto-Rivera equation, first described in 1948. This equation outlines a key role of venous pressure as a contributor to hydrostatic pressure within the capillaries. Venous pressure is directly transmitted backward to the microcirculation, increasing the hydrostatic pressure in the capillaries. So yes, it contributes to the capillary hydrostatic pressure, but not in a 1-to-1 ratio. In this experimental study in dogs, Paul Johnson demonstrated that approximately 62% of the venous pressure increment is transmitted backward to the capillary in the intestine. So if we gather all the data available in the literature and depending on the tissue considered, 60 to 80% of the venous pressure is transmitted back to the capillary pressure. In this figure, you can see the relative contribution of the venous pressure to the capillary hydrostatic pressure on the y-axis across a wide range of ratios of resistances on the x-axis. So the blue line corresponds to an increase in venous pressure to 25 millimeters of mercury instead of 15, which is normal. The higher the venous pressure, the higher the capillary hydrostatic pressure. To put it simply, it means that hydrostatic pressure is more sensitive to an increase in venual pressure compared with a similar magnitude of increase in the arteriolar pressure. And actually, a pressure change applied from the venous side is 5 to 10 times more effective in changing capillary hydrostatic pressure than when applied from the arterial side. So, of course, there are some consequences because the hydrostatic pressure is directly correlated to the transendothelial flux, the JV. So, as we said earlier, the main driver of transendothelial flux is the hydrostatic pressure. In this revised Stalling equation proposed by Woodcock, any increase in hydrostatic pressure above the J point threshold substantially increases the transendothelial filtration. And because this curve is left shifted due to an increase in vascular permeability, let's say during sepsis, for a similar raise in hydrostatic pressure, it may result in a significantly larger net fluid filtration towards the interstitium, of course exceeding the capacity of lymphatic drainage, and therefore contributes to tissue edema formation. So again, this is largely theoretical, but what about the clinical evidence? So there are some extreme cases in the literature on the consequences of a steep increase in venous pressure. In this case, this is a story of a 39-year-old man with a severe left ventricular dysfunction in whom an LVAD, an HeartMate 3, as I remember, was implanted as a bridge to transplantation. The early postoperative course was uneventful, but on postoperative day 10, this HVM clip was obtained while the patient was in stable clinical condition with otherwise normal LVAD parameters. So in this video clip, you can see an obvious stasis of the red blood cells with very enlarged venules. Later on, the patient deteriorated and required a reoperation because of hematoma and tamponade. Several studies have linked central venous pressure and organ dysfunction such as AKI in different clinical settings. There's actually a paucity of data examining the link between venous congestion and microcirculatory alterations in sepsis. An interesting work comes from Valinga and et al. In this post-hoc analysis of a prospective study in septic ICU patients who were resuscitated according to a strict non-CVP guided treatment protocol, they examined the differences in microcirculatory variables in patients with a CVP lower and greater than 12. They found that the MFI was higher in patients with a CVP lower than 12. And in addition, the percentage of perfused vessels was higher without a significantly increased TVD or PVD. So it means that the convective component of the microcirculation is possibly improved, while the diffusive component remains unaltered, at least within the time frame of the measurements. Impact of venous congestion has been recently highlighted in a review on intra-abdominal hypertension. Intra-abdominal hypertension plays a key role in AKI, leading to a dilation of the postcapillary venules due to venous hypertension. This is followed by an increase in hydrostatic pressure, of course, that in turn causes increased fluid shifts. This vicious circle goes on and on. Now let's consider less critically ill patients. So in this small study, including post-cardiac surgery patients in the ward, we looked at the sublingual microcirculation during 3 days. All these patients left the ICU with a positive fluid balance, weight gain, and most likely a possible venous congestion, but were otherwise stable with normal macrohemodynamics. On the first day in the ward, patients exhibited lower TVD and PVD. However, microcirculation was gradually recruited with a parallel increase in PVD and TVD with the use of loop diuretics. So it means that the diffusive component was recruited, but it also means that venous congestion can manifest in different ways in the microcirculation, highlighting a certain temporality of events. So the temporality of fluid resuscitation or deresuscitation has been discussed many times, and the same may apply for the microcirculatory derangements associated with venous congestion. At the early stage of fluid management, let's say within 2 hours, venous congestion is of course unlikely to happen. In the few hours following a resuscitation, it is possible that venous congestion develops. And it is likely to happen in the afterwards, let's say after 24 hours. Fortunately, these questions will be answered with the Andromeda Shock 2 trial and the analysis of venous congestion with the VEXA score. So venous congestion can be assessed at the bedside with the use of ultrasound and the VEXA score. However, it remains to be proven that the VEXA score correlates with microcirculatory alterations. Now let's consider a patient with a more chronic venous hypertension. Pulmonary artery hypertension is often associated with right ventricular failure, dilation or dysfunction, and of course these patients are at increased risk of venous congestion. In this study, including 26 patients with PAH, an analysis of the sublingual microcirculation with the help of an HVM was performed just after a right heart catheterization. So it is worthy to note that 2/3 of the patients had right ventricular dysfunction or dilation and enlarged inferior venous cava. Interestingly, CVP was rather normal. So the authors observed a significantly lower mean flow index and a greater heterogeneity and tortuosity of the microvasculature in this patient. And interestingly, none of these microcirculatory alterations observed here were correlated to right atrial pressure, conversely to what has been observed previously. So the role of right ventricular failure is important in venous congestion. We've been facing COVID for a couple of years now and see a lot of patients with RDS, mechanical ventilation, and high levels of PEEP. The problem is that there is consistent data showing increased mortality of patients with right ventricular failure or dysfunction. So it can be assumed that the increase in venous pressure contributes at least in part to this higher mortality rate. Because in patients mechanically ventilated, the threshold for considering a high CVP is increased, it is complex to consider a static parameter reliable. In this study, the authors analyzed the portal vein pulsatility index, PVPI, which is considered a surrogate of venous congestion in post-cardiac surgery patients. They performed PEEP increment trial from 0 to 15 and observed a parallel increase in CVP and PVPI. So these results indicate that PVPI could be a useful non-invasive tool to monitor venous congestion associated with mechanical ventilation. A question remains, however, is this a nice tool for assessing microcirculatory tolerance to PEEP? So the remaining question is, can we adequately measure microcirculatory venous congestion? Well, the problem of pressure artifacts has been outlined in several publications and should be properly assessed and reported according to quality scores. Indeed, large venules are very sensitive to an external pressure applied with the HVM, and only 25 grams is enough to induce pressure artifacts. Some devices have been proposed to overcome this problem, but have never made their way into routine use. Fortunately, the pressure artifact is notably reduced with the latest generation of HVM weighing approximately 130 grams. And these pressure artifacts are even more pronounced when hemodynamics are compromised. Here you can see that the HVM clip have a higher validation score failure when the mean arterial pressure was below 50 due to pressure artifacts. So the NIRS may provide an indirect measure of cerebral venous congestion, for instance. In this study, there was a relationship between a cerebral NIRS and CVP, best described as an S-shaped regression curve, with high CVP, above 20, being associated with cerebral desaturation. And it is known from a long time in the field of cardiac surgery that obstruction to the venous flow is the first thing to check in case of cerebral desaturation and reposition the cannula eventually. So this is nicely illustrated in this case, where a very steep decrease in cerebral desaturation occurred on one side during CPB, with a parallel increase in the internal jugular vein pressure up to 60. The cardiac surgeon repositioned the superior venous cava to solve the problem. The stressed and unstressed volumes have been assessed with the help of the NIRS and a calibrated cuff pressure monitor at the bedside. So this technique is not very convenient and is cumbersome. The stressed and unstressed volumes can actually be measured with a reinterpretation of the parameters provided by the NIRS in combination with a standard cuff pressure monitor to induce venous congestion. So here the authors performed a PLR in septic patients. The PLR increased the unstressed volume without significant effect on the stress volume. So sensu stricto, it is not a measure of venous congestion, but rather an assessment of fluid tolerance of the venous compartment. So there are some options to treat the congested microcirculation: nitrates, loop diuretics, lower PEEP levels, or renal replacement therapy. Which is best really depends on the clinical setting. Future challenges in managing microcirculatory venous congestion will be to readily identify the responders. Greenwood et al. Applied topical sublingual nitroglycerin to detect reversible microcirculatory dysfunction. They assessed sublingual microcirculation with HVM before, immediately, and after application of nitroglycerin, and 30 minutes later. On the one of the striking results that is that nitroglycerin can identify responders and non-responders in terms of heterogeneity and perfused vessel density, while all patients had similar microhemodynamics and especially CVP. Application of nitroglycerin improved both the diffusive with an increase in PVD and PPV, and the convective component with improved red blood cells velocities. So it is not known whether nitroglycerin acts primarily on precapillary sphincters or on the venous microcirculation. So what are the future direction? We need parameters to identify congestion on HVN clips. So will it be red blood cells velocity? Will it be the diameters of the venules, the pressure test? I don't know yet, but we require an automated analysis for doing that. And we will move forward for personalized medicine with probably more and more pharmacological dose test response and probably adapt ventilator settings. So we've seen that a loss of hemodynamic coherence can exist with near normal mean arterial pressure and cardiac output, but what is not known is whether the same happens on the venous side. In other words, does an increase in venous pressure always impact the microcirculation? We also do not know what is the time frame of microcirculatory alteration in case of venous hypertension, immediate or delayed. So here are the essential messages. The increase in venous pressure will in fine lead to tissue edema. Assessment of the effects of venous hypertension on the microcirculation is challenging, and the microcirculation alterations secondary to venous congestion can manifest in different ways. If it is very acute, then the convective component will be altered first, and if it lasts, this will impact the diffusive component as well. Thank you folks for listening, and I hope I didn't bore you too much. I would be happy to answer any question you may have. Thank you.